Okay, well, good evening, everyone. Sorry for the delay, and thank you for everyone for taking the time to jump on this evening and just hear an update from our team. So we've got a little bit of everything from all the disciplines that are just going to give some different information and takeaways from the national or the North American Cystic Fibrosis Conference that we recently attended at the end of September. And I am going to kick it off in a second, but I'll introduce him later. But before I forget, I did want to just point out the fact we have a new pulmonologist. So for those who may have not have had the opportunity to meet him yet, Dr. Gardner, he's on the screen smiling and waving. So we're very excited. He's a new pulmonologist to us, but he has a lot of experience and did his fellowship with Chapel Hill. Has started with us recently and is seeing our cystic fibrosis patients. So you may see him in clinic and get to know him, but we're very excited to have him and he'll be reporting out later. But we wanted to kick it off. Hopefully the Brooks made it on. I don't see their name. Okay. All right. So we were going to kick it off. It looks like Beth, they're there. Beth and Tim, they are part of our family advisory board. So anyone that's not aware of our family advisory board, we have a website. Please reach out to me if you have any questions or interest in participating in any of the initiatives that we do. But we've been lucky enough to send representatives from our family advisory board to attend NACFC each year, and the Brooks had the opportunity to go this year. So we just wanted them to just take a couple minutes, and I'll cut you guys off if I need to at any point. I know we have a lot of speakers tonight, but we would love to hear from them and just what their experience was like. So I will let Tim and Beth Brooks take it away. So go ahead, guys. You're muted. We can't hear you. All right. Maybe I'll move on to the next presenter if while you guys figure out your technical difficulties because dog is barking. I don't want to get too far behind schedule. So let's see, who did I have on? Your next, Sarah. So our pharmacist, Sarah, Dr. Murray.
Oh,
I'm so sorry.
Sorry, just got in.
Oh, okay. Okay, so go ahead, Brooks.
Sorry about the technical issues. We're working on our phone tonight. Our computer decided not to behave.
Well, pretty much we were asked to attend NACFC on behalf of the Family Advisory Board and being parents. For our first time going, it was quite overwhelming, to say the least. We kind of knew what to expect from other board members that have been, but it was amazing to meet all the amazing Cystic Fibrosis Foundation people, other physicians, researchers, scientists. It was, you don't really know all the people that work behind the scenes and have a passion for finding a cure, finding new medications, things like that. It's really kind of gets you really motivated to go out and fundraise and do things to help the foundation just because you see what the money is going to.
Yeah, that's correct. We just enjoyed meeting people from all over the world. I mean, the first plenary night, seeing 5,000 people together in a room, knowing that only a small handful were actually people related to or caregivers of people with CF. And everybody else was there because they chose this profession or they chose to research it. It just blew my mind. And so, but many of the things that we found most interesting were all the sessions we went to. And we had a couple that we decided were like our top picks. One was learning about the CF Foundation and all the new things they have going on with their community outreach, their community voice, their care, and how they're trying really hard to connect the CF community because in the past it was such a lonely disease. And they're trying so hard now to get like children and young parents, maybe connect them with an older set of parents that have teenagers or even adults to help kind of guide them through the first few years of what it's like to be a CFer.
And one of the main topics this year is obviously the CF care model has needed to be changed with Trikafta and other modulators coming out. The kids or patients are more healthier. So, I'm sure some of the physicians and staff are going to talk about the CF care model coming up, but they're looking at care. They're looking at also by introducing these modulators and other possible cures, they don't want to have something else come up. I mean, there might be, they have to look at cancer screenings now because patients are living longer. So it's just I guess the CF world has changed drastically over the last few years for the better. So it's exciting to see where they're headed. There's a lot of motivation and urgency to find a cure and find modulators for everyone, and especially the 10% of those that do not qualify for that. So that was the big thing from the conference this year was, the urgency.
They're not stopping.
Until a cure is found.
Yeah, just because Trikafta came out, they're not going to just say, okay, one and done. They're going to keep going. They're going to find something for everybody. The other thing that I thought was interesting was through the social part of it, social workers and dietitians were talking about now that our kids are getting older, how is technology, as in TikTok, YouTube, how are those influencers affecting our kids, And I like that that's being addressed, that that's being brought up, that, we're not just ignoring the mental health aspect of this, that we're embracing it, because these kids are turning into teenagers. They're going to be young adults. They're going to be adults. They're going to be grandparents, hopefully one day, so they're introducing so many more aspects of the new lifestyle that these kids are facing. And I appreciate that we got to set in on that session. And then finally, like Tim said, they're looking at everything. They did one for bone density and talking about how, men and women, we need to focus on not just children, but adults, and, testing to see how the modulators are going to affect their bones as they age.
And one of the plenary sessions actually was talking about reproductive health.
Mm-hmm.
They've never really had to address that until Trikafta. So, there's a lot of things going on. You could tell there's a lot of stuff going on behind the scenes too, that the science staff is working on that, they're excited about. So a lot of bright things in the future to come. And, we were very excited to go and look forward to going again soon sometime.
That's awesome. Well, we always appreciate having parent representatives because I think, or I know that you have a unique perspective and can bring back great information. So thank you. I think, Rachel, maybe we'll just move right on and save some questions to the end just to expedite timing. So we do have Dr. Murray, or Sarah, our pharmacist, who works with our adult and pediatric clinic, and she will go next.
Hey, everyone. Thanks for the introduction, Beth. I am going to touch briefly on a new modulator coming out. This is a very brief overview, so if you want to talk about it more in clinic, we definitely can. But so far, we have Trikafta, we have Kalydeco, and we have Orkambi and Symdeko. And there is another new modulator that is called, well, right now they're calling it Vanza, because we don't have an actual name for it. So Vanza triple, sorry. So the reason why they're calling that is because it's a triple modulator therapy. It's going to have the tezacaftor that Trikafta has. It's going to have vanzacaftor, which is another corrector, similar to the elexacaftor and Trikafta. And then it's going to have a different ivacaftor. So it's called dutivacaftor. And the reason why they changed up the ivacaftor is because they wanted to make a medication that could be once daily. So with all these other medications, you're having to take it twice daily. And it's usually because of the ivacaftor portion only lasting 12 hours. But with this new modulator coming out, it is a once daily triple therapy. So that is exciting. It's going to be indicated for people with CF, 6 years or older, with one F508 deletion mutation or another responsive mutation. It is currently being reviewed by the FDA, all the data is, and so we're supposed to hear back by early 2025, so fingers crossed. And in terms of safety monitoring, it's the same as all the other modulators. It will require quarterly LFTs. Even if you're on a different modulator, we'll have to repeat those since this is a new one. So quarterly for the first year, annually thereafter, and then the annual eye exam is recommended. Next slide, please. All right, so there is a lot of words and a lot of numbers on this slide. I'm just gonna touch the highlights. Vanza triple has 3 main phase 3 studies to look into the safety and efficacy. So the first 2 studies, Skyline 102 and 103, are for ages 12 and up. The 102 study, the patients had one F508 deletion mutation and one minimal function mutation. And in the 103 study, you could either have 2 F508 deletion mutations or one 508 deletion and a gating or residual function mutation. In the Ridgeline study, this was for ages 6 to 11 years old, and this was for anyone with at least one responsive mutation for ages 6 to 11. There is a long list of mutations that these modulators are approved for. So the biggest thing for these studies, they did a Trikafta run-in period for 4 weeks. So all patients were on Trikafta for 4 weeks, and then they took baseline measurements. And then in the Skyline studies, people were either randomized to Vanza triple or to Trikafta. In the Ridgeline study, so our 6 to 11-year-olds, everyone was switched over to Vanza triple. They looked at FEV1 from baseline in the Skyline studies as their primary endpoint, and Vanza triple was non-inferior to Trikafta, aka just as good as Trikafta when it came to FEV1 percentages. And then they also looked at sweat chloride reduction, and Vanza triple showed a greater reduction in sweat chloride compared to the Trikafta group. When they looked at the pooled results of both the Skyline trials, for patients that had less than 60 for sweat chloride, there was 86% in the Vanza group and 77% in the Trikafta group. And then for sweat chloride below 30, there was 31% in the Vanza group compared to 23% in the Trikafta group. So pretty much so far, Vanza triple is showing that it's just as good as Trikafta and can reduce sweat chloride even a little more. And then in our kiddos for 6 to 11-year-olds, the primary endpoint was safety. The side effects were comparable to Trikafta. So most common was the purge, typical cough, upper respiratory infection, nasopharyngitis, and then some diarrhea and headache. In terms of FEV1, Vanza triple affected these patients about the same as Trikafta, but it did reduce sweat chloride even more. So something to note, this medication is not going to be for everyone. It is going to be very patient dependent. Patients with a history of elevated LFTs were not included in this study, so might have to tread lightly. But if you'd like to hear more about it, just let us know when you're in clinic. And I did include, I think, on the bottom of the slides, some links to these studies that you can look a little deeper into.
All right, awesome. And yes, feel free to put any kind of questions or comments in the chat and just let those accumulate so you don't forget, and we'll address them at the end. But thank you, Dr. Murray. And now Dr. Gardner, who I had mentioned at the beginning, our new pulmonologist, he is going to present next. Thank you.
All right. Thank you, Beth. And good evening, everybody. Thank you for joining. And I'm excited to be in Atrium in Charlotte. I am just briefly back me. Can you go to the next slide? Born and raised in North Carolina. So I grew up in Apex in the Triangle and then did undergrad at Elon and went to med school at Brody, East Carolina, then went to residency and fellowship at UNC. So luckily, Charlotte had a job open for me and we were able to get back to where my wife grew up in Charlotte. So really excited to be here and excited to work with the CF community here. This is my most recent picture from this is actually ATS, and I presented a little bit different of a project, but it was my most recent picture, professional picture by myself. So that's me, and I want to get you guys updated on some key findings and some exciting stuff coming down the pipeline. So went to a lot of different sessions, but I wanted to highlight a couple, mainly being the nucleotide-based therapies for those not eligible for Trikafta or elexacaftor, tezacaftor, ivacaftor, and then also looking at a really neat session about engagement barriers, listening in CF communities of color. Happy to chat about any of these other ones at a different time. But here are some key points. So we're going to see this slide early on, and then we're going to see it again at the end. And I know there's going to be a lot of great speakers and just some take-home points I hope everyone remembers. So there are about 10 to 15% of patients with CF who are not eligible or intolerant of modulators. We have inadvertently increased health inequities through modulators, and that has to do with a couple of different things that we'll review. And then key features to improve care for all patients with CF include novel therapies, participation in clinical trials, and engagement in discussions with these different communities and populations. There's a 2-hour video here. You can see NACFC, a session that I attended. It's wonderful. I hope you have a chance to view it. And if not, I'm going to try to summarize everything in the next couple minutes and slides. So here is the problem. And this is updated from CF registry. And you can see on the side here that 94% of patients have F508del or other CFTR modulators that are approved. And that includes this 10% of people who are eligible, but either don't tolerate it as well. So not everyone's eligible, and this adds up to, like we were saying, like 10% up to 15%. And of those people that are eligible, there's significant side effects that can develop. We're learning that as our patients, we start them younger, they're exposed to that therapy for longer, and going through teenager is difficult on everybody, but we're starting to learn a little bit more about the side effects of CFTR in the brain and how that can affect behavior and mood. And some people have to stop it for depression. We also know about elevated LFTs and kind of liver disease and how that affects Trikafta, and if we're able to stay on it or do we have to back off of it. Another interesting point is that CFTR modulators are wonderful, but they really do not correct all the different organs where CFTR is found. So, for example, CF-related diabetes is still going to be a major concern, and there was a plenary session dedicated to this. We also know that patients who are taking CF modulators are now more likely to have recurrent pancreatitis, and before patients with pancreatic insufficiency weren't at that same risk. And then lastly, we think about distal intestinal obstructive syndrome. So there are lots of things that, although Trikafta has been a wonderful medication, there are some additional things we have to think about. And then the other problem that kind of speaks to me is that we've created this health inequity. So those patients that are eligible for modulators, when developing a medication, we wanted to go after the most common variants and how could we affect the most people. And so that really includes F508del and some other variants, but unfortunately, these variants are most common in the Caucasian population. So So now we have to look really at populations of color and our Hispanic groups as well. When we think about this worldwide, we know that not everyone has access to CFTR modulators. We are so lucky to be in Charlotte, where we have an amazing team of pharmacists and social workers and nutritionists and everybody. So, but across the globe, it's not the case. And then we also know Trikafta is expensive, and so we had a patient the other day, and there was at odds in with the insurance company and who was covering what, and the Trikafta was actually suspended for a little bit. So this is really important that we think about, how do we go forward and what do we do next? So some possible solutions. Theratyping is a really interesting concept, and so those patients who have variants that haven't been tested in clinical trials, they may be eligible to kind of submit their cells to be tested in a lab. And so there's different organoids and there's different patient-specific cells where you would go in and either give some of your blood or cheek cells, and the lab and the scientists would go back and they would be able to look at the effect of modulators at the cellular level. And that might give us more information. And even though they didn't technically qualify based on Vertex's criteria, they might be able to meet it on the scientific level and kind of have that trial. This is important because in clinical trials, we need large number of participants with certain variants to have a high enough power to say the results are reliable. So for example, if you have a clinical study with just a few amount of patients, you don't know if the results are truly going to apply to the mass population, or if they're just for that kind of sub-segment of patients. So this could be really important as we move forward, developing a kind of standardized approach for theratyping, and also thinking about patients who may not be eligible for Trikafta, but find a different avenue for proving that it works at the cellular level. Next is new treatment modality. So this has been involved. This has been going on for several years now. So I'm sure Dr. Shellhouse has been promised this for years, and hopeful by the end of my career, we'll have this all figured out. But nucleic acid-based therapies. And I wanted to mention this because it's getting a lot of attention recently. You might have seen this about sickle cell, and you might have also heard about this through SMA or spinal muscular atrophy. So there's a couple different broad categories. One is antisense oligonucleotides that affect different variants. There's mRNA therapies, and there's DNA-based therapies as well. That includes gene replacement therapy. So those are like viral vectors. So you code a protein, you code a certain segment of DNA, you put that in a virus. That virus then goes into the patient's cell and injects the virus into the host. And then there's also gene editing based therapy, which if anybody remembers their Gattaca movie, it's kind of like that, where you target the variant of interest and you go in and you kind of cut on one side, cut on the other side, and then you join them together. So these are all pretty amazing kind of scientific discoveries, but more in the exploration phase. I included this graph over here. It's I'm sure we go over this at every visit. I like to touch on it kind of in my first visit with my families and kind of think about what's going on at the cellular level. So on the left column is how the regular protein is made. So you have DNA that goes to RNA, that goes to your CFTR protein, and then it goes to the cell surface. And in patients who have variants that are not eligible for Trikafta, a lot of times they have either deletion effects, so that's this class 1, where they make the mRNA, but then the mRNA is either not spliced correctly, or there's nonsense variants, or there's deletion variants. And so sometimes that causes no protein. So then you don't have anything to modulate. You don't have, Trikafta is not able to fold or chaperone something that is not there. So that's when these DNA and mRNA and antisense oligonucleotides become a possible solution. Next slide. So here's where we stand. We have a couple of nucleic acid-based therapies that are in the works, a couple in phase 1. So you can see the AAV, that's the adenovirus I was talking about, mRNA, the antisense oligonucleotides as well. So these are in phase 1. And hopefully, we'll have to go through phase 2 and phase 3, but it's to show you that there are several that have kind of got through the preclinical phase and have shown some efficacy at the cellular level, and as well as some different ones that we're still working on. Next slide. So moving forward together, one powerful testimony I heard from a mother, and it was also brought up in a different session as well, was that a mother of a patient was approaching their pediatrician and telling them all the symptoms of that the child was having, recurrent chest infections and malnutrition signs. And they also had a different child with CF. Excuse me. And so they said, like, I really want my child to be tested for CF. And they said, great, okay, we'll do a sweat test. And that sweat test was normal 2 or 3 times. And the pediatrician said, look, your child does not have CF, and goes on to say, your child is Black, they cannot have CF. And so, we as a CF community and know that's not true. And to think like how that would feel as a parent when you're saying there's something wrong with my child needs help. I know that they have something else going on, and to be dismissed by the physician, it's really a powerful story. So I hope we can change that. I hope we're going to do better in the future. And here's how we can do it. So we know that there are 1,100 adults in the U.S. that have CF and are eligible for modulators in meeting certain criteria. And about a third of those are people of color and or Hispanic. And so this makes up a pretty significant group and somewhere where we have an opportunity to do better. And so we can do that by education. So I think that's our first thing is going to be how can we educate families and looking at our demographics now, can we help out any of these patients and help their families and have their family members talk to other family members, because we know these variants can easily be missed. So if I'm seeing John Smith in clinic, it say, well, tell me about mom, your cousins and your uncles and things like that. Does anyone have recurrent chest infections? And kind of making sure that they're aware that this is a genetic condition, that all family members are at risk if they have a child with CF. I think we can also focus on educating the medical community as well. So we are working on expanding diagnostics. And so that kind of ties in with newborn screening. There was a pretty detailed session about newborn screening. And right now, every state is different. And so how do we approach that? And there were a lot of stories in that newborn screening sessions where patients of minorities that were missed based on their sweat levels were, I guess, really their IRT wasn't triggering the newborn screen, or their sweat tests were indeterminate. And so those variants that are higher frequency in minorities need to have a better diagnostic. And so my future and hope is that we'll transition to whole genome sequencing and targeted sequencing in the future. I think participation in TDN and clinical trials is going to be really important as well. As we were mentioning in a couple slides ago, is that with these rare variants, we have to have higher numbers. And so I'm hopeful that we will be able to participate in the therapeutic development network, the TDN, and we'll be able to contribute these patients. Engagement and discussion. So just learning from the community, being involved, being there, and hearing from the Family Advisory Board and the CF Foundation of how can how can we help these population, and how can we help everybody out? And then also, I think Kendra's going to get to this later, but talking about registry data and just how important that is. And so we can better understand the variance and the clinical outcomes, and we can have quality improvement measures to make sure everyone's getting excellent care. Next slide. All right, so these key points, so wrapping up here for me. We know that 10 to 15% of patients with CF are going to be not eligible or intolerant of modulators. We have inadvertently increased the health inequities, but there are ways around this and ways that we can get better. And those key features to improve care for all patients include novel therapies, participation in clinical trials, and engagement and discussion with all communities. Next slide. All right, so these are not my kids, but this is a very special patient with CF of mine who has given me approval to use this message. And I think it just displays, this was one of my first ever CF patients. And I met them in the PICU after getting a bowel surgery for meconium ileus. And so parents were rightfully very worried and thinking not only acutely of, is my baby going to be okay, but also what are the long-term effects and what does life look like and airway clearance. And so it was a really amazing opportunity for me to step in and have that physician and family relationship and be able to provide them with some comfort and some care. They ended up being, this girl ended up being pretty sick for the first year of her life. And so it's been an incredible journey to have that relationship with her and to walk along her and the family and to get them better. And she's made a remarkable recovery and has her central lines out and her G tooth out. And she had an ostomy and that's been taken down. And so a great outcome. For those of you who know George Resch Bogart, Dr. Bogart, he's one of my mentors from UNC. And, a lot of this, he was responsible for newborn screening in North Carolina. And he was also pretty high up in the leadership with CF Foundation and CF. And so I was texting him about my first CF clinic, and he told me to enjoy the journey and that this is the best job in the world. So I just want to say thank you all for what you do, and thank you, CF community. And I'm going to turn it back over to Beth.
All right, awesome. Thank you so much, Dr. Gardner. Next up, we have our pediatric dietitian, Emily Ash.
Good evening, everybody. Go to the next slide. Okay, so I'm going to talk about nutrition, obviously. So I had a really interesting session that I went to that discussed problematic eating behaviors. I'm sure everyone has had a toddler at some point and have had the difficulties that come along with just the different stages of childhood. So it was found that eating is more stressful in children with cystic fibrosis than non-CF children, and that can be a lot of reasons. A lot of times your own providers are probably part of the problem and have added a lot of stress to your lives, especially when it comes to growth. So just identifying that is also really important. So some of the problematic eating behaviors that they discussed is the refusal to eat, some texture aversions, choking, gagging, or pocketing food, which is basically, like a chipmunk or a squirrel would do, which is hide it in their cheek and not actually chew and swallow. Prolonged meal times can be a problem, and that especially comes into problematic when it comes to taking their enzymes and just having that time frame of when they're allowed to have meals during that time. And then also preferring to eat or to drink rather than eat, having a poor appetite, and then having mealtime tantrums. Slide. So they came up with what's called a modified behavioral pediatric feeding assessment, which is very long. word for just a screening tool to like see if how your child's eating is affecting or their behavior is affecting their eating. So this is kind of what it looks like. It's a 3-page document. And so it's just titled Learning How to Eat. So some of the things it talks about is like, will the child try new foods? You know, do they enjoy eating? Do they not enjoy eating? So there's a scale as far as they never, they sometimes, they always, and then it discusses, is that a problem for you as a parent or is it not? And you can go to the next slide. So after it talks about the child's eating behaviors, and it talks about how the parent's response to that. So how do you respond to their behavior? So it asks questions about your behavior during mealtime. And then they also said that they started this as early as 9 months of age. So the point of this is, again, it's a screening tool. So it's not diagnosing a child with anything. It's just a way for us to help identify if there is a problem going on. I feel like a lot of times, you know, we were talking about CF can feel so isolating. But a lot of times parents have a hard time describing what's going on and they kind of think that it's just a normal, but it may not be normal. So this is a way for us to detect those things early so that our problem can be addressed. So depending on how they do on the screening, we can either address it in clinic and just talk about it, or, you know, if it's bad enough, we can also refer them to feeding therapy. So I just thought this was a really interesting tool that I thought the Family Advisory Board might want to talk about to see if this is something that may be worth our while in the future as far as implementing it when it comes to your child in clinic. Next slide. Okay, so this is a hot topic. We talked a lot about the effects of our highly effective modulators when it comes to what it does to the pancreas. So there's a lot of discussions about that, and I've honestly been asked this a number of times already, so I thought it was appropriate for us to talk about it in this setting as well. So the hot topic is retesting exocrine pancreatic insufficiency. So the particular study that I'm going to talk about, it was completed across 3 CF centers to see if fecal elastase improved after starting a highly effective modulator therapy. So one of the centers was actually UNC Chapel Hill, which is just up the road. So we can assume that their patient population is probably pretty similar to our patient population. So I just thought that was interesting that we can kind of see what they found and kind of assume that it's probably pretty similar to our patients. So they retested the fecal elastase after 6 months of being on a highly effective modulator therapy. So some of the major findings were children that were started on therapy greater than 12 years of age, the fecal elastase did not improve, unfortunately. However, younger agers had a greater increase in their fecal elastase. So their sample size was 70 people with CF across, again, these 3 centers. And of those 70 people, 15 had a fecal elastase of greater than 200. So that's around 21%. So we'll talk a little bit about the specifics of that, but what those 15 patients look like is that 60% of them had at least one F508 del mutation, and then 46% of those patients also had a gating mutation. 67% had an initial modulator was ivacaftor. The average age that a modulator was started was actually younger. And then they were also able to 13 patients were able to completely stop their PERT or their enzymes. So that's just kind of what those 15 patients looked like. And again, it's kind of a smaller study with only 70 patients, but it is exciting, something to think about for the future. They did say that the centers continue to monitor for growth symptoms of malabsorption and your fat soluble vitamin levels. They did say that they were cautious with borderline fecal elastase of 200, and they also didn't necessarily, even if someone's fecal elastase improved from their original amount, if their growth wasn't really great, they didn't take them off of their PERT. So they were just, that was one thing that they cautioned about it. They also had different guidelines between the different centers. So they had different criteria or protocol that they followed. So that kind of makes it tricky as far as developing guidelines because they were all different. So they concluded that they need some more research in order for us to provide guidelines across the entire CF community. But I thought this was interesting, something to begin talking about.
All right, thank you so much, Emily. So we will move right along to Rachel Isom, which is our adult dietitian. So take it away, Rachel. Uh-oh, did we lose her?
She should be coming back on right now. Here she comes. There she is.
Hey there. I didn't realize that my camera wasn't allowed to be used with this app.
No
Can you see
problem.
me?
Go.
I don't.
Yep, you're all good. We
Okay.
can hear you too.
Sweet. Well, you can go to my slide. I kept it short and sweet. And we'll go in a little bit in depth on each topic. I'm always so excited to come back from NACFC. It's so exciting to me to be around other people who are in the same field as me with the same excitement as me about CF and nutrition. So hopefully I'll share a little bit of that today with you too. So one of the things that happened in several of the sessions that I was in where they talked about pregnancy and CF. So many women who become pregnant with CF, it's not a planned pregnancy. And so from a nutrition standpoint, it's definitely an area where I think about my patients, and if they become pregnant and they're not preparing for pregnancy or thinking about becoming pregnancy, there's potential that we can miss out on some nutrients there. So part of my practice kind of, ping like, oh, maybe we'll want to talk more about nutrients of concern like folic acid or choline or omega-3 fatty acids like EPA and DHA. When we talk in the clinic, we'll just talk about foods that those come from because that makes sense. Are you having foods that contain these nutrients? And if not, we might offer some suggestions to help you incorporate those. So that's something I took away from several sessions. I also went to a session the Brooks talked about earlier on body image. And I think they brought up some great points about how social media can influence body image. If you're wondering what does this term body image mean, it's those collection of thoughts and feelings a person has about their body. We talk about bodies a lot when our patients come to clinic. And I think it's important to keep those conversations individualized with each of them that are coming. From the dietitian standpoint, some of the previous conferences have also incorporated talks about being more weight neutral with our patients when they're coming to clinic. And so I think that's always a good spot to meet the patients where they are and continue to provide that individual care for each one. Some of the neat research topics that I heard about during conference, there was a clinical trial that was done called Anagram. They finished phase 1. It was a very small study, so definitely more to come. But in that particular study, individuals took an enzyme alternative where they had one pill with a meal, and it did work to help with absorption of the nutrients from that meal. And so it's kind of exciting to see where things will go with a bigger trial, with more people, and hopefully more meals to see how well that one pill can do with absorption. I was also excited during one of the sessions I went to, talked about body composition. I complete bioelectrical impedance. So BIA, it's a term we might use. We have a machine called the N-Body in clinic to help measure and discern body composition. So saying, hey, what's your muscle mass is a great way to look at it. One of the sessions mentioned that there is a study that's ongoing called Strong CF that is assessing nutrition and muscle development in people with CF. And hopefully one of the things they're going to work on are CF specific calculations that we can use with the N-Body or with that BIA equipment. And so I'm excited to see how different those equations would be compared to the current ones and how that can help my patient. That's all I have prepared.
Awesome. Thank you so much, Rachel. All right, up next, we have our CF nurse navigator for the pediatric clinic, Kendra Blevins.
Hey guys, can you guys hear me?
Yes, you're good.
Perfect. So I'm going to talk a little, well, I'll start by saying one of the things I found the most interesting and was excited about seeing was the new care model updates and care guidelines that is being published, and Dr. Chalice is going to share more about that. So I'm going to help and assist our registry coordinator in giving just a little bit of an update about that. So for those who may or may not know, the CF Foundation has a patient registry that collects information on the health status of people with CF who agree to participate. So we collect things such as your culture results and labs, your height and weight when you come, your lung function. And after you come to a visit, then we just plug all that in to the registry. And the registry is actually getting ready to update. It's not been updated in a long time. So we're getting ready to start next year, have a new next gen registry. So that's exciting. That'll be more efficient in collecting these items. And so there's been about 50,000 people followed with the registry since 1986. And so it collects some critical data that helps with different things. So it'll help the care teams in providing care to individuals with CF, identify some new trends, which we'll look at some of those on the right, and then develop some new clinical care practice guidelines and guide quality improvement initiatives at your care center. So different centers will take this data either for just, we can do a QI initiative with just the data from our center, or when people are doing research studies, they'll get permission to use the registry across the board to impact their studies. So it's a great tool for people to see what's going on with people with CF across the country. So if for some reason we've missed you and you are not consented to be in the registry, ask about that at your next visit. But they put this little graphic together for us and sent it out earlier this year about the 2023 data and some highlights. And it's really cool to see some of this stuff and how the registry's flipped and how the 18 years and older was 8,000 people in 2003, but now 20 years later, there's 20,000 people 18 years and older. Also, the little pregnancy baby boom that we've had, seeing the pregnancies jump is really cool. And then transplants have went way down. So you can look at 2018 the year before Trikafta came out, and there was 259 transplants. And then last year we only had 61 transplants, and those with CF. The graphic is also there too, how we can see that our population is changing as far as race and ethnicity, and we're identifying more of those people, which is very important. And like Dr. Gardner was saying, to be able to identify treatments that will work for those people as well. And they're very important in our CF population also. And our CF patients that are getting older are also living more normal lives. So they're going to school, they're having jobs, things like that. So it's really cool to see how it's growing. So that's why the registry is important. So we can collect that information and use it for just different following trends and doing different research studies and identify people who are identifying things that can be changed by information we have. So that's all I have on that.
Okay, great. Thank you. Up next, we have Dr. Zach Held, who is our pediatric cystic fibrosis psychologist.
Can you see me?
Yep, can hear you too.
Awesome. All right, so next slide. So I'm going to try and keep this brief. There was a lot of really cool stuff at NACFC. I think one of the coolest things that I saw was the plenary on reproductive health, which I know has been touched on a little bit. But what I took away from that, from a mental health perspective, is, we didn't expect these kind of benefits for reproductive health with Trikafta, and Trikafta is just working a lot in areas of the body that we didn't necessarily expect it to work in, and we can kind of expect now that it's potentially working also in the brain, and we just don't fully understand it yet. In terms of research, there's not been any real research that supports that Trikafta has a negative impact in mental health, but there have been anecdotal cases and examples of little kids with increase in behavioral problems or increase in anxiety or depression in adolescence. So it's possible that in some populations and kids it does impact mental health, and we are still learning about that. From my perspective and from what I kind of learned from the conference, I think there's a lot of interpersonal difficulties, and there might be some changes in mental health symptoms that are not due to necessarily the biochemistry, but due to increase in kind of quote unquote normal behavior. So for example, kids might have more work at school because they are attending school more often because they're not getting sick. They're gaining weight easier, which has been well documented. So there's a lot of body image issues, or kind of relearning what portions they need to eat and to not gain weight. But there's also more time to spend with friends. And it's great that they're not missing out on this time to spend with friends, and they're experiencing all these experiences that normal kids and teenagers would experience, but that also potentially means more interpersonal drama and more kind of just regular kid and adolescent drama. So we're kind of replacing a lot of the burden of care and the impact that has on mental health with kind of more typical adolescent and child mental health concerns that we'd see in kids who are attending school and attending all these activities with friends. Specifically, Trikafta is having a lot of added mental health benefits. I think Beth is going to talk more about sleep and mood and how that improved on Trikafta. But most of the reports that have been seen for worsening mental health in Trikafta were patients who had pre-existing mental health concerns. So I think if someone has been diagnosed with depression or anxiety or any kind of mental health concern, and then they start Trikafta, that would obviously be something we'd want to monitor, as most of the people who have had mental health concerns that have gotten worse have been kids or adolescents who have had mental health concerns pre-existing. In a longitudinal study that was presented at the conference, which means over a long period of time, 6 months follow-up, 90% of patients had no changes, or they improved in terms of their mental health status who are on Trikafta. So we're seeing 9 out of 10 people don't have any changes, or they actually improve. There are some support in case studies for some mental health concerns. So if your kids are experiencing mental health concerns, we do obviously want to know about it. It's not unheard of, and we take it very seriously. I think from my perspective, stopping Trikafta just because of mental health concerns, depending on what they are, obviously is not necessarily kind of our first line of defense. We can treat the symptoms, they can come to therapy, and there's a lot of ongoing research in mental health with Trikafta, which I think is going to be coming out over the next couple of years. I will say for patients who are not eligible with Trikafta, we've seen some mental health concerns, and a phrase that really stuck out to me from one of the presentations was kids with CF often talk about feeling different, and the kids who are not eligible for Trikafta feel different from feeling different, meaning they're already feeling different from their peers, but now they feel different from the CF population that they've been a part of for most of their lives because they're not eligible for Trikafta. So definitely want to keep that in mind, keeping a close eye on our patients who are not eligible for Trikafta for mental health concerns as we kind of move towards more treatment. The CF Foundation always talks about working on a cure until it's done, and I think we can look at that from a mental health perspective too, of supporting all our patients until everyone is eligible for treatment. So That's all I have.
All right. Now I'd like to introduce myself. So for those of you who don't know me, Beth Jorgensen, I'm the pediatric social worker. I'm going to try and go really quickly through my slides. I have a really hard time trying to just like summarize or pick a couple things. So something I found interesting, there was a presentation about a clinic who did a pilot study about procedural anxiety and just how they're seeing a real increase in this and just kind of the detrimental effects that if it's not addressed, like PTSD and that carrying into even adulthood. And obviously with the modulators going down and dropping to younger ages and kids having to get regular blood work and sticks for checking LFTs and things, it's becoming more and more common. So just trying to make this the least amount of traumatic as possible for all parties involved, because we know it's not just traumatic for your child, it's also traumatic for you. So some suggestions that they had with doing this pilot in preparation for coming to clinic, just being honest and describing what's going to occur at the visit, letting your child know what to expect and what is expected of them, using age-appropriate, non-threatening language. So this would depend on the age of your child. Play. So this is especially for those young kids, modeling or acting out a procedure, whether it's a swab or blood draw or a shot. Letting them, you can get a little doctor's kit and letting them play and give you a shot, you give them a shot, just being able to explore it, talk about it, get comfortable with it, destigmatize it. So being able to do that between clinic visits to kind of prepare them mentally for coming in. Also preparing a special bag that you bring to clinic that has toys, books, stuffed animals, a device that they can use during the visit. Next slide. So utilizing those toys, special toys or shows, that's just for clinic. So maybe they have a favorite show that they watch and you only allow them to do it during clinic to kind of make it a little bit more rewarding being there or a little more tolerable for them. And then if they are having some kind of blood draw or when they're getting their swab, having a stuffed animal comfort item for them. Trying not to overwhelm them. So, deciding how many people you're going to have in the room, who's going to be in the room, not giving them too many choices, not asking them, okay, can I give you this? Well, that would be from our end, that we're not saying, can we, do this swab now? We're saying, would you like to sit on mom's lap or are you going to sit on the table to get your swab or your blood draw? Do you want to hold my hand or someone else's hand? Distracting them with conversation, story, video, play, normalizing that they have fears and their reactions, not minimizing that or making that a bad thing. And obviously this being a collaborative effort between our staff, so our lab, whoever else is there potentially to help. It might be Kendra that's in the room. Also, for those who aren't aware, we do have child life. So making sure, you can request that you have child life be present. We may already have requested that they be present and that they have their special tools that they can utilize to make it a little bit more smooth as well. And then after the visit, celebrating, praising them, words, hugs, high fives. We have stickers, reminding them why it's important. Sorry, you can move to the next slide. Congratulating them and being an active partner in their care and that, they're doing such a good job taking care of themselves, letting them choose their rewards. And then the next slide. But not apologizing for what's happening, avoiding bribery or punishment, which I think everyone's just trying to do their best. And in a moment of panic, when you're trying to get this done and you need this blood work and your child is understandably upset, we're all just trying to do whatever we can to get it done. And trying to keep this scenario similar each time so that kids know what to expect. And hopefully after, it's not going to make it night and day the first time, but hopefully after a couple visits that this is going to become something that is a little more expected, that they know the routine and it'll be less anxiety provoking for them. And just modeling those desired behaviors. So I think for everyone involved, being able to control our own fears and anxieties and be able to model that for the child, because obviously we can reflect that and impose that on those around us. So if we're upset, it's only going to make them more upset. So trying to support one another and work together as a team, and that's between our care team and parents, and the lab and everyone. So Zach did check, sorry, next slide. Yeah. Did touch on mental health. I just wanted to say I went to a lot of really interesting sessions. I was really encouraged by all of the pilots and studies that are being done. I feel like there's a lot that's in process that kind of just ended with they need more research, which is exciting and a little bit discouraging because we want to have all the answers now. There was a lot of talk about considering screening for anxiety and depression younger than 12. So this is, sorry, I'm on the slide before that. This is something that we will consider and talk about. So don't be surprised if we start talking to you about potentially doing some standardized screening for younger than 12, which is our current standard. Another thing was talking about screening for more than just anxiety and depression. We're seeing a lot of sleep issues, ADHD, substance use, like I said, procedural anxiety, body image issues. So there was some talk about coming up with like a composite screener that would address all of those, or just kind of the most important topics to really find out what pediatric and adult patients are struggling with to be able to target our interventions and provide support. With continued reduction in age, with Trikafta, there have been a lot of studies on how sleep is being affected, behavior, physical symptoms, and interestingly, I think some people have experienced where we've tried like swap dosing, so like changing the morning or the night, or reduced dosing, and they had seen some early positive effects on that. So that's something interesting to see how the continued studies will go to see, if that's a placebo effect, or if that's truly for some reason how that's helping. So a couple people had talked about sexual and reproductive health. I think this is something we're aware that we definitely need to focus more on. I think it's not a comfortable topic for some people to talk about. So just trying to remove that stigma and making sure, especially in the pediatric clinic, we're starting early with explaining age appropriate things and making sure that our patients are well educated and feel comfortable to ask questions and get resources. We are actually going to be piloting solo adolescent visits for age 16 and up. So just to have an opportunity to talk to a 16 and up patients by themselves without parents in the room. And hopefully this will give us an opportunity to have those more sensitive conversations and assess sort of what patients know and what questions they might have. And because it is a pilot, we definitely welcome any feedback and suggestions that parents have. And that will segue into my next slide, which is just anytime you come to clinic in the pediatric clinic, you will see this in the room. And this is a survey link that is available that you can fill out after a clinic visit. And it's de-identified. So it's an anonymous survey where you can provide feedback from your visit. And this is really helpful information just to see how we're doing and help us to improve our care. So please, when you're in clinic and you see this, scan this QR code and fill this out so that we can get some feedback on how we're doing and how we can improve. Okay, I'm sorry that we are running behind schedule, but our last presenter is Dr. Shahas. And as you're probably aware, we are recording this. So if you do have to jump off, you can be able to access a later date. So next up is Dr. Shahas.
Okay, I don't know if you can hear me or see me, so say yes or no.
Yes, we can.
Okay, let's see if I can get, I can't see my camera is not coming on. Not sure why the camera is not coming on.
There you are.
There it is.
Yeah, I see you. Yeah.
I had to just press it a few times. Okay, so I'm going to talk about the CF care team model. I'll try to go through this fairly quickly. I think the bottom line is initially you're not going to see many changes in what we do in clinic, but hopefully over time you'll see some increased partnerships. So next slide. So just to, I don't know how many slides we went, just to let you know, there's a reason that we're an accredited care center, or there's several reasons. And the main reason is that you get better care. There are more people who know about CF at the care centers. They're available to you. They're usually always in clinic, and they can answer your questions. We also have other functions, though. We educate non-CF physicians and providers. We work on improving our care. A lot of people have talked about research. We actually are involved in a couple of those Vertex studies. And hope to be involved in more. We've talked about the registry data, which helps us improve our clinical outcomes. We love our local CFF chapter, and we have a lot of mutual respect and support for center to chapter and chapter to center. So I think that's really helpful to you as families and patients. And we provide education and resources for community, families, and patients. Next slide. And so the CF care team model, the simple answer of what it is how we do things to care for people with CF. The solo physician practice has gone out of style many years ago. And it's because it's not easy to know everything about everything. And physicians and care providers need help from each other. So we have a team, and that team is multidisciplinary. It provides care that is guideline-based, and we work hard to improve outcomes, advance research, and hopefully in the near future to discover better treatments and potential cure. And the CF care model is really the first of its kind. It started in the 60s and has progressed until, so it's 60 plus years old. And it has become the standard of care for many other chronic illnesses. Next slide. And what is that? What are the results of that? Well, one of the results we've touched on, life expectancy has greatly improved from about 30 years of age when I started to now over 60 and accelerating. I think patients born today who are eligible for modulators are going to live a long and hopefully happy and productive life. Next slide. We've also touched on this, which is the research drug pipeline. When I initially started in this game, you could get all of the research projects on one slide. This is just a sampling. We've talked about the genetic therapies briefly. Dr. Gardner or Sarah touched on those. We also talked about CFTR modulators. There are actually some other modulators that are in the pipeline. The Vanza triple is hopefully coming soon, but people are interested in making these better medications with less side effects. And there's 3 times as many studies in the pipeline than I can show here. Next slide. I want to just make a brazen, blatant commercial plug, but this is another reason you come to CF Care, come to the CF clinic, and we have a care team model, and that is to provide you with preventive things. We want to prevent you from having flu, COVID, and RSV. And how do we do that? Well, it's done through immunizations. Flu shots, annual flu shots have been around for a long time, almost all my career, and they prevent you from ending up in the hospital or in the ICU or from dying from flu. So please get a flu shot. COVID vaccines, I know in the current political climate, they remain somewhat controversial, but we now have a number of years of data, safety data, and efficacy data, how effective they are. And they are almost as good as flu shots. So, and there's a new booster available. So please think about getting a COVID vaccine. And for those of you who have young children, there is a condition called RSV, which all young children usually get in the first 2 to 3 years of life. But for kids with chronic illnesses, particularly CF and other diseases that affect the lungs, our immune system, RSV can be very terrible. And so now we have an RSV shot. It's called Beyfortus. And if you're 19 months or younger, you are eligible for it. It's also now given to pregnant women. So if a mother who has a potential baby with CF in utero in the last trimester, you can get Beyfortus and hopefully prevent your baby from developing RSV in the first several months of life. So very important vaccines that keep you out of the hospital and out of the ICU. Next slide. Well, this is the care team model that we've worked with for a long time. And at the center, you can see a patient and family. And then we have a small group of required team members, which you see in the clinic every time you come or almost every time you come. And then around that group, there are other people that have been recommended and other specialists. And this has functioned well for a long time. But now we have changes. We have good changes. With the modulators, we have increasing life expectancy. We have increasing quality of life. And we have people who are going to do things that maybe they never dreamed of doing or never dreamed that their children would do in the future. Getting jobs, having careers, being involved in professions, becoming parents, etc. So there's been a lot of thought about what this model should look like. So next slide. This is the reimagined model, is what I decided to call it rather than the new model, because it's really care team model 2.0 rather than the 1.0, which we just looked at. And inside, built on a foundation of what we call programmatic components, we already do this, but this is just to bring them out as recognized parts that every CF care center should have. And that's a good microbiology lab who can identify the specific bacteria or germs that affect people with CF, a good statewide newborn screening program. All 50 states do something different. So there's a move to try to make this more standardized across from the CF Foundation and from other CF experts. A good pharmacy with pharmacy technicians that know about specialized CF medications. We've talked about the registry and research, but we need coordinators to help us do that. And obviously the sweat test lab is extremely important in that first few months of life in making a diagnosis, and probably is important in determining how well your modulators are working. So that's the foundation. On top of that foundation is the core team. In the last 5 years since I've been here, we've added a mental health coordinator. And that really consists of two people. That's Beth Jurgensen as part social worker, part mental health coordinator, and Zachary Held as a psychologist. So we've added that persons. We've added Sarah Murray as our PharmD, and she is supported by pharmacy technicians who she helps educate and keep up to date in newer CF drugs. And we will be talking about genetic counselors more. We've always had a genetic counselor available to us, but they are now considered part of the core team, not only for diagnosis and working through that, but also as people with CF and as parents of people with CF decide about future pregnancies. Outside of the core team, then in the green, there's essential partners. Those are people you may have some familiarity with, particularly the gastroenterologist, but there are other people on that list. And the primary care provider has always been an essential partner, but is now really recognized as that essential partner. So that list is very important, and we need to probably work out ways of communicating with those people better. And then on the other side, in kind of the purplish color, are the trained and trusted people. Those are people that occasionally you need outside of the CF core team and essential partners. Those are like the allergist, or maybe you have a heart condition and you need to see a cardiologist. or we've had a couple of people who have childhood cancers who need hematology oncology. An eye doctor really maybe should be part of the central team, but certainly we need eye doctors for people on modulators who need annual eye exams. So I think you'll see an expansion of the care team. And the reason there's an expansion of the care team is because people are living longer. And as now an older adult, you have more problems as you live longer. Most of them can be managed and you can have a great quality of life, but managing them earlier is better than waiting till they're more problematic. So that's the brief of the core team. We're supported by the national and local CF foundations and by Compass. Compass, for those of you who don't know about Compass, I don't know if we're having a slide on Compass, but it's really the advocacy group for people who are having difficulties in dealing with parts of the CF related care. So insurance, for example, maybe you're having some other difficulties that life, school, other life issues. Compass is there to help direct you. Next slide. All right, that's all I have. There may be questions for all of our speakers or comments people want to make. So now is that time.
Yeah, don't see any questions in the chat, but definitely feel free to type anything in the chat, or if you want to come off mute to ask anything for any of our presenters this evening, feel free to do so. Otherwise, for those who don't have questions and need to go, we thank you guys for jumping on tonight and participating. We'd love to get feedback for future events that we provide, and what sort of content everyone is looking for from your care team. Yeah, just spread the word to everybody so we can connect with more families. All right, just everyone giving us compliments. We'll take it. All right, well, we'll stay on for a couple minutes. Rachel, I don't know if there was anything else you wanted to say, but if anyone, we'll stay on for a couple minutes if anyone has any questions, but thank you guys for logging on.
Yeah, no, I just want to say thank you so much to the Atrium CF care teams, both the adults and pediatric centers. I appreciate y'all's time and your feedback about NACFC. Also, I appreciate the shout out for Compass. Yeah, it's insurance, it's legal, it's, if there's issues in your home with mold or education or any of these areas where you need an advocate to help you locate resources, that's what Compass is there for. So please, yeah, be sure to take advantage of that. And yeah, we're just so thankful to have such an amazing care team right here in Charlotte. And I appreciate all of your time.
I guess one last comment I just wanted to make especially clear is that there are many of the presentations from NACFC that are available on YouTube. So we can share that website and you can watch plenary sessions and other recordings of available sessions that I think a lot of you would find interesting. Okay, we have, how will we be able to access the recording of this presentation? So I will make sure to send out the link to everyone, but we do have a family advisory board website where we archive all of our recordings, and I believe, I'll double check on it, but I think it's just Charlotte CF Families, and I can send that out as well. Yeah, charlottecffamilies.org. So it's just Charlotte and then cffamilies.org, and you can see any past presentations and recordings we've had. And when that becomes available, we'll edit this and get that put up there, and we'll send the link out to everyone as well, so you'll have it. And yes, Samantha also mentioned there is a Charlotte CF family Facebook page. So there is a public one where they put announcements regarding different events. But then there's also a Facebook page that you can join to talk to other people. So just to make you aware of those in case you are interested. But on the Facebook page are links to the YouTube recordings of the plenary sessions from conference. Yes, the parent group is called Carolina CF Families. Oh, and it's only for parents. Hence in the name, I guess. So. All right. Well, thank you again. Sorry we ran long and we had some technical difficulties in the beginning, but if you think of anything later, feel free to reach out to either your pediatric or adult team. And again, we appreciate everybody for joining us this evening.